organized by the FBC Care Vets. Our session, Confronting Despair, Addressing Depression and Suicidal Thoughts in Cancer Patients and those struggling without a medical diagnosis, will touch on matters that deeply affect many people, regardless of their background or belief. It is our privilege to introduce our speaker today, Dr. Daniel Fung, who holds a PhD in clinical psychology and has extensive experience helping individuals navigate emotional and mental health challenges. His compassionate approach and professional insight have provided support and hope to many, especially those facing the weight of depression and despair. Dr. Daniel's sharing today will guide us in understanding how to approach these difficult topics with care and empathy, helping us support one another more effectively, whether you are here out of personal experience or to learn how to assist others. We hope this session offers valuable perspective and practical tools. Please join us in welcoming Dr. Daniel Fung.
All right, sounds good. Great. Thanks, Eve, for that very kind introduction. Can you guys hear me? Can everyone hear me? Should I throw my voice louder?
Louder, please.
So I speak up or the mic needs to come up? The mic needs to come up? Oh. Hello? Test, test, test? Yeah, I don't think... Did it get turned off? Oh, it did. Wow. Now we're good. Is it too much? Too loud now? Too echo? I can't stop my own echo. All right, keep talking. All right, is it better now? Is it better? All right. All right, first off, thank you everyone for having me. It's a privilege to come and talk with you guys about something that's fairly near and dear to the kind of work that I do and the people I see. The next thing I just want to say real quick is I apologize for not being able to stand up today because I injured my foot on the field yesterday in a football tournament, which reminds me I'm not very young anymore. So it was a bunch of dads. All of us were dads, but even then I got injured. So so I apologize about that. So I just want to maybe really quickly as we get started, as we're still waiting for the PowerPoint to come up. Is it? Oh, it's good already? Okay, good. I just give a real quick introduction to myself and what I do. I have worked in basically a lot of mental health settings. And so that's both inpatient and outpatient. So meaning in the hospital, in the psychiatric hospital, that's primarily where I've spent most of my time, about 7 years, 6-7 years in that kind of setting. And then the rest of it is mostly outpatient, so community mental health, like your clinics, I guess, for mental health where you see counselors or psychologists, and then also student counseling centers, training centers. I've also seen patients in medical settings as well. So things like primary care, so like in GP clinics, you come to see your GP, but then you also get to talk to the psychologist there. So that's the kind of setup it was in the US. So, and I've also worked in cancer care, so seeing patients who are diagnosed, first diagnosis of cancer, all the way up to as they are dying of cancer. Literally, the doctor says the cancer has metastasized, you have 2 weeks to live. So that's kind of the range of patients I've seen in medical settings. There's a few others as well, weight loss programs, weight management types of programs. It's a bariatric program is what it's called. And then also like smoking cessation. So these are kind of like medical type settings I've also worked in, but they pertain to mental health. So today we're going to be talking about this idea of confronting despair. In there, we're going to try to understand what is depression and what is suicidal ideation. So suicide itself is kind of a big topic that has kind of many splinters into that. So I'll talk about, hopefully give a good accounting in that. into those terminologies. So I just want to say that the goals are threefold for today. One is to introduce a bunch of terms, but also really just the scope of issues that pertain to when you talk about this idea of depression or suicide, right? What do they mean specifically? And then also then to let you guys have maybe hopefully have a more working knowledge of what the assessment and management of the issues are, specifically with depression and suicidal ideation. And then the third one is how to apply that in your setting. So I'm assuming not everyone here is joining Care Bears, but some of you here are and are interested. And so that's the application portion, that third goal, essentially. So are the slides up or are they still waiting? Okay, yeah, so maybe later if we have the slides, but basically 3 goals for today, okay? All right, so the first thing I just want to kick us off is to talk about what is depression, okay? We've heard that word thrown out a lot. People say, oh, I have depression, or like someone has depression, and that word has become more, maybe for lack of a better word, more sexy over the years. It's become more easy to use, like, oh, that person has depression, say that person is very sad. So, but we understand that more now that it is a disease. It comes with a bunch of symptoms. So when people say depression, right, they mean a bunch of different things. But in terms of what we think about as diagnoses, I just want to talk about 3 kind of types of, there's different types of depression. I just want to talk about 3 big types of depression. One is what we call major depressive disorder, all right? MDD for short, major depressive disorder, right? That's the one that most people think about as clinical depression, okay? That's the one that has, basically you have an acute period. It's an episode of depression. It's like the flu. It comes, it stays for a while, and then it goes. Okay, usually it's fairly short term. It has to be more than 2 weeks long for a bunch of symptoms. And I'll talk about those symptoms here shortly. But it stays for about 2+ weeks. It can range to like over 2 months, over a year even sometimes for some people. Just like certain flu symptoms, right? It can also do that. But the time period is at least 2 weeks, but no more than 2 years. Okay, so that's clinical depression. The second one is what we call persistent depressive disorder, or more commonly back in the day before they changed the official diagnosis, it used to be called dysthymia. And dysthymia is basically more like a long-term chronic depression. Great, we have it up. I'm on the 3rd slide, if that helps. I think there is a presentation button to hit as well on the settings side of things. Maybe it's that 3-button thing. The top right. You can put it on presentation mode basically, so that you don't have to scroll up and down. Yeah. Like that. Yes, perfect. Thank you. So I'm on the 3rd slide. Yeah. So there are 3 basic types of depression. I was talking about the second one, which is persistent depressive disorder. Now this one, the symptoms aren't as acute, meaning that you don't have as many symptoms, but it's more chronic. It's much more long term. So it's at least 2 years long. So some people call it like a low-grade depression, right? It's longer, but not as many symptoms, not as severe, basically. The third one is what we call like an unspecified depressive disorder, which is essentially like a subsyndromal depression. So we call this like minor depression. You kind of have some symptoms, but it's not very long and it's not very many. So you kind of have a minor depression, but not what we call major depression or dysthymia, which is chronic depression, like a long-term depression. So these are the 3 types of depression. So bear this in mind as we move on. So next slide. So when we talk about diagnosing depression and looking at how we tell someone has depression, there are 9 symptoms that we look at, okay? And I'll talk about a major depressive disorder. For an MDD, you have to have either the first or the second symptom in there plus 4 more. Either 1 or 2 plus 4. And the first one is a depressed mood, like a persistently low depressed mood, which is essentially feeling down most of the day, nearly every day, for at least 2 weeks. So it's more than just, but that particular criterion for it is actually, with a symptom, when you hear that, it tells you that it's more than just sadness. Our emotions swing from day to day, right? Some days we're feeling energetic, motivated. Some days I kind of roll out a bit. I'm going to force myself up, to jog, to get to work, or to go to the gym, or to do something. We got to force ourselves to do those things. We are dragging on those days. And some days we're just kind of down. But if it lasts for more than 2 weeks, and it is most of the day, nearly every day, you have checked symptom 1, all right? But that doesn't mean you have depression yet, major depression. You still have to have at least 4 others. So I'll talk about 2 to 9, all right? The second one is what we call anhedonia, which is essentially like a loss of interest or a decrease in your interest or pleasure in things that you enjoy doing. So let's just say you enjoy fill in the blank, you enjoy gardening, you enjoy watching movies, you enjoy reading books, whatever it is, fill in the blank, you start to feel like you don't really have much interest in doing it anymore. Or if you did do it, you have interest in doing it, it doesn't feel the same anymore. It doesn't feel like you're deriving any sort of satisfaction or pleasure from doing it. Now, that is what we call anhedonia, that loss of interest or pleasure. Okay? So, either 1 or 2 is required, as I said, for a diagnosis of MDD. So there's a few others. As I go through 3rd to 9, you will see a lot of them are actually behavioral markers. The first 2 are like subjective experiences, which is depressed mood, right? A low mood. The second one is a loss of interest. It's an internal mechanism, internal change. But the third one, we are talking about appetite or weight changes. So sometimes when people get depressed, they eat a lot or they stop eating, right? So that has to do with your appetite. Or when they get, so part of that is because, so there's a lot of people with depression who have like very unhealthy weights, either too heavy or too light, like anorexic level light. It's because there's a lot to do with food and how it also affects your brain. So we eat for pleasure. So a lot of people, so especially younger people, in the 20s, are more prone to to overeating specifically. When you're older age, it can be either you eat too much or eat too little. So it's quite common, especially in geriatric ages, to actually sometimes have that loss of appetite. So you see people don't really want to eat very much. They don't feel like eating because food tastes kind of bland. They don't feel like it's something they enjoy anymore. They don't want to. And as a result, their weight also drops. Muscle mass drops, muscle tone drops. So, but that's what we're trying to track either their appetite or we're trying to track their weight. Those are behavioral indicators. So those things will fluctuate. And the degree to which they fluctuate, if it's quite a lot, then because even our weight and our eating also changes. Sometimes we eat a lot, sometimes we eat a little. But if it changes a lot from your baseline level, meaning say for example, in 1 month you lost 5 kg, that's quite a lot. We consider that a lot. If 1 month you lost 2 kg, we can accept that. That's not maybe a big loss. So we track that over time. So maybe after 3 months, whoa, you lost 10 kg, that's a lot. Unless you were purposefully dieting. So appetite changes, weight changes, that's a big one. The fourth symptom of depression is tied to your sleep. Now you might experience sleep disruptions. Normally you hear people throw about the word insomnia, right? Insomnia is when people have a hard time falling asleep or staying asleep, okay? But there's also hypersomnia, which is difficulty waking up in the morning. So sometimes people sleep too much. So either you sleep very little or you sleep a whole lot. So again, this, you have to know your baseline. I don't take it at face value that someone who comes in and says, oh, I'll be sleeping 4 hours a week. I don't take it that means they have depression, that they meet criteria for sleep disturbance. Because if they normally sleep 4.5 hours a week, then that's normal for them. Because some people are like that. Their bodies are wired to be able to take 4 hours of sleep. Whereas some people, they need more like 9-10 hours of sleep. In fact, actually, if any of you have teenagers at home, encourage them to sleep that 10 hours because for their growing brains, it's actually a good thing. But unfortunately for our teens, a lot of them like to sleep not very much at that age. So sleep disruptions, essentially, insomnia, hypersomnia. Okay. The fifth one that we're looking at is what we call psychomotor retardation or agitation. So what that looks like is that, so retardation, psychomotor retardation, what that really means is there's a lot of slowing in your movements. You move a whole lot slower. Normally it takes you, say, 20 minutes to shower and get ready. Suddenly you find yourself taking an hour to do that. Normally you might take, you might do laundry, fold and hang the clothes, say half an hour. When you're folding, you're hanging, and then later on fold the clothes, half an hour. But then suddenly you say, oh, it's taking an hour and a half, a lot longer. So you're cooking longer, you're doing your chores longer, whatever it might be. And you find that slowing is also part of the mental processes. One of them later on, poor concentration, number 8. All right. So that's common. Sometimes people slow down a lot, or sometimes instead of slowing down, they feel like they got a lot of energy, but it's kind of very restless energy. They just kind of feel on edge. They can't sit still, and they're very listless. So it kind of just, if you've ever been bothered by that, you know that that's not a comfortable feeling. It's also just as bad as slowing. Because sometimes slowing is like, okay, you're going at a very slow pace, it is taking a lot longer to finish things. But this one is like, being restless is just a very uncomfortable feeling wherever you are at. So that's that's psychomotor agitation. Okay. The sixth one is a lack or loss of energy. So that one is essentially fatigue. So if you're really just tired, and part of that is you slept your usual, say you might have slept your usual, say 8 hours, you just still wake up tired. You wake up just exhausted already. You haven't even gone about your day and you're tired. Or maybe you had a shot of energy at the start when you wake up, but it lasts maybe 2-3 hours. By noon, you're done. You need to take you feel like you need to take a half day off for the rest of the day because you're so exhausted. So fatigue is one of the symptoms of depression. The others are, the seventh one is interesting because again, this one comes back to feelings. It's not so much what we call a behavioral indicator. This one is a subjective experience, right? But it's what we have is excessive guilt. So sometimes people get very guilty about what they've done, or they feel very worthless, that their lives are not worth very much. So I once had this patient, he came to my hospital, showed up. He was like in his early 20s, maybe 21, 22. He tried to kill himself. He threw himself off the 3rd floor. They have a 3-floor house. From like the balcony of it, he tried to basically let himself fall backward into the ground, and so that he would die. He didn't die. He broke his hip in the process, and then couldn't move. And it was winter time, and so he lay in the snow for like almost 3 hours before someone found him. So he's freezing cold, in a lot of pain, and then he shows up in our hospital. So that happens sometimes, but when we try to probe as to why that happened, right? It's not the psychiatrist couldn't really get a sense. The psychiatrist was the leader of the team, couldn't get a sense of it. But I had some of my own suspicions, and later on it turned out to be true. One of the big things that drove him to guilt was because he came from a Catholic household and he was watching pornography. So he felt very guilty and worthless, which then drove him to attempt suicide. So again, you can see how this falls under that constellation of depressive symptoms, guilt or worthlessness. All right, the eighth one is, again, a behavioral indicator. It is poor concentration, having a lot of difficulty just trying to concentrate and pay attention, or difficulty making decisions, being decisive. So you dither a lot. So it's a lot like the same process of like psychomotor slowing, except this one is a mental slowing. So you're a lot slower to think about things, you calculate things slower, if that makes sense. Okay. And then the last one, which is also what is tied to today's talk, the last symptom, the ninth one that's related to depression is suicide. All right. And this one comes in the form of suicidal thoughts, having a plan, or even attempting suicide. It's even as, I guess, maybe let's call it as passive, as having recurrent thoughts of death. You're not really thinking about killing yourself, but you keep thinking about death itself. If those thoughts come over and over again, they can be interpreted as a sign specifically of suicidal ideation. Okay? So again, sometimes people have these experiences, but when they occur in a cluster, at least 5 of these symptoms, right? That makes what we call that major depressive disorder. Okay? All right. And I just want to also make a point. I made a point at the bottom that I said notably, like each individual's depression profile will look different. And why does it look different? It's because you need only 5 out of 9. Right? The first, either you need 1 or 2, and then any other 4. And so what that means is, technically 2 people with depression might have very different symptoms. The first person might have number 1, 3, 4, 5, 6. The second person might have number 2, 6, 7, 8, 9, which means their depression looks very different. It might be that some people have a lot more symptoms. Some people will have 7 out of 9 symptoms. Some people will have 9 out of 9 symptoms. And then sometimes we don't have this specifically under the symptomatology, but it gets so bad that so I talk about psychomotor slowing, right? Where people move very slowly. Sometimes people don't move at all. They basically just sit up in bed. And they can do that for hours. Right? We call that a catatonic, very catatonic behavior. You're to the point that you're almost like frozen. And to get up to do one thing to the next takes so much effort. You're so sluggish. Or you could be having to the point of like psychosis. You could be seeing or hearing things that other people don't see or hear. That is an example of like when it's pretty severe as well. Okay? So again, depression is not the same for everyone, because some people have, even for major depressive disorder, they have different specifiers, meaning like different tiers. So even though that's considered clinical depression or major depression, there's some people with major depression, like this is really severe for them. And those tend to be much longer term, much more fixed, much more what we call like treatment resistant. You got to do a lot to work through that stuff. So I don't know if there are questions at this point, but I'll just put it out there right now that if there are questions, feel free to raise a hand and shoot out a question so that we kind of can change things up a little bit every now and then. That said, I will also leave some room at the end of today's discussion, maybe about the last half hour or so that we can address questions from the audience as well. Okay, next slide, slide 5. All right. So I just want to go through some statistics related to depression. I just want to compare basically a general population, the idea of depression in people in general, but also for cancer patients in general. How does depression look like for people in general versus cancer patients? All right. So in the general population, there's many ways to cut the cake, so to speak. A lot of health organizations, what they do is they look at like maybe a 12-month prevalence, which is how many in the last 1 year. In the last 1 year, how many people reported they had depression, right? So the prevalence in the usually in 1 year, the last 1 year, is usually roughly about, depending on the study you're looking at and the people they are sampling, it's usually about between 5 to 8.5%. Okay, which in Malaysia is quite actually concordant with that. So there was a study done last year, actually the National Health and Morbidity Survey, NHMS, so done in 2023 by the Ministry of Health, revealed that about 1 million people in Malaysia, or 4.6% in Malaysia, of those over age 15 were suffering from depression. Okay, so that's it. Lifetime prevalence is a bit different. It doesn't look at the last 1 year. It looks like you ask people at any time in your life, did you or were you diagnosed? Did you have depression or were you diagnosed with depression? Right? So this is not the last 1 year, but at any time in your life. So they look at a bunch of people. That one obviously is higher, a higher number because not just the last 1 year. So the range of that one is anywhere from like 5 all the way up to 16.6% if you ask people at any time in their life. But average is about 12 in average study. 12% of people would say, yeah, I have depression. So that means when you're looking at around like more than 1 in 10 people will have had depression at some point in time in their life. This is past tense, have had. Now, the next line there is the lifetime morbid risk. Lifetime morbid risk is not just those who have had depression, but those who will have depression. So it's counting the risk of those who will have depression. Now, when you count people who will likely get in the future, that's closer to 30%. So the likelihood of a morbid risk, meaning anyone getting depression, having had depression or about to get depression, or may get depression in the future, that's about 30%. It's almost 1 in 3 people will have depression. Okay. All right, so a few other things kind of as you think about the statistics, depression affects women more than men. Depending on the study you read, I remember the rule of thumb they taught us in graduate school is that 2 women for every man has depression. But then I think the studies kind of range about 1.5 to 3 basically. So it could be, it's in a range. And there are different reasons for that. Sometimes people say it's because men are more stoic and they don't express much, so they won't admit to those depression symptoms, whereas women are more expressive. They tend to be more open at least with confiding with their healthcare providers. Okay. A few other statistics as well. In terms of like those who are 18 to 29, it's higher than a lot of people who are older. So depression usually hits when people are younger, in their young. So it starts at the puberty age for a lot of people, and it peaks into the 20s. Afterwards, as a population subset, less people have depression. That said, later there is also what we call like a late onset, meaning for someone experiencing depression maybe in their 50s or 60s for the first time. That also is not uncommon, meaning it happens commonly enough as well. Okay. All right, I didn't put this in there, but one of the other risk factors as well is if we have like, if we have a first degree relative, that means a parent or a child or a sibling, parent, child, or sibling with depression, it increases our own risk for depression typically, meaning like there is some genetic component to this as well. So about 1.5 to 3 times more likely. So there's a lot of factors. People used to think that it was as to why like depression is happening, but people used to think it was just in the brain, your brain chemicals are wrong. But they're starting to find out that the brain chemicals are wrong because of other things. It's happening secondary to other things, meaning as a result of other things that throws our brain chemicals off. So it's not specifically, depression is not the brain chemicals per se, but these brain chemicals are changing as a result to a lot of different things, which I will talk about some of them today. Then comparing with cancer patients compared to the general population, I just want to say that just like with most major illnesses, cancer patients are more susceptible to being depressed. So you can see it's more common, it affects them, so the 12-month, or so the prevalence rate, they didn't actually say whether it's 12 months or lifetime, but it affects about 20 to 25% of cancer patients. Some smaller studies even show up to 40%. There was this study done with breast cancer patients, about 100 plus, 140 something people in that study, and 40% of women reported depression, at least on a minor scale. It affects men and women equally. That's one thing that's changed. So cancer evens it out for the men, maybe, I don't know, with end-of-life considerations to become more expressive and admitting they have a mood issue, something that has related to themselves, but it evens it out for the sexes. And that's one other thing that's interesting to note is that depression in cancer patients receiving end-of-life care is no more prevalent than cancer patients living actively with cancer. Okay, what that means is that even if inpatient, so there's 2 different populations, right? One, end-of-life care, they know they're going to die for cancer patients. Then there's the group that's still actively battling cancer. They don't know. The prognosis is still not clear yet, but it actually doesn't change, meaning like depression rates don't actually go up even if you're facing end-of-life care, which is actually really interesting because sometimes we assume that would happen. So sometimes, like when I was working in cancer care, I get calls from doctors, who just delivered the news, to say, so one of the patients would get news about their cancer that's metastasized, and they literally tell him, you have 1 week to live. And then he's like, okay, and literally they will page me to go talk to him because they think he might be having depression. And I go in there, I assess him, he understands. He was in his 80s already by then. He was also ready at some level. Like he knew this could come, and it was not out of depression specifically that he didn't want to talk to his doctor. He was quite real about it. He was accepting that this was going to come. And so that's very different from what we think about as depression specifically. All right. Sorry, just a quick second here as I peruse my notes. Got the sequence wrong. Okay. All right, we can move to the next slide. Thanks. So, why does knowing about depression matter, right? Why do we care about it at all, right? I actually get this question quite a bit from patients especially parents of teenagers who come to me. They will ask like, my time don't have one, right? My time don't have depression one, right? But then nowadays, all these kids, why they have? Why is it an issue? Why is it becoming known? What is the issue with this? So the big answer, I guess maybe easy way to answer that question, why it's important, is this phrase that we use, which is the burden of disease. Major depressive disorder, as indicated by the World Health Organization, back in 2008, said that it was the third cause of this burden of disease. This idea of burden of disease is that when you are diagnosed with something, a condition, whether it's a medical condition or a mental health condition, I myself don't really make a distinction between mental health or medical condition, because to me, a mental health condition is a medical condition. So when you diagnose someone with that particular disease state, how does that impact them, the burden of the disease? So it impacts you in several different kinds of ways. It impacts you in terms of the economics, the finance side. It impacts you in terms of what we measure in terms of lost health. So when you think about it, the 9 symptoms I described earlier, in some ways, they are more intrusive, more debilitating than cancer itself. Cancer itself is an external thing, but you are working a lot of your resources to fight it, but you could still potentially sleep good, right? The one thing about cancer that overlaps with depression, for sure, is the fatigue part. A lot of cancer patients feel fatigued. But the other parts, sometimes they might have like a chemo brain as well, like the concentration difficulties. But by and large, a lot of cancer patients, especially the ones that don't experience the chemo brain part, say doing BMT, a bone marrow transplant, that's less likely to happen. You might still have good sleep, you might still be able to enjoy your food, not overeat or undereat, you might still have a lot of interests and pleasure in things. Now depression, you don't have a lot of that. So in some ways the burden of disease of depression is very heavy, meaning the impact on your life, how much it changes your life and your lifestyle, is very heavy. So again, depending on health organization, they count it in terms of like financial costs, loss of income, and also a big one is basically the lost health. So one what they call DALY, daily, which is disability related. So how much it disables you. It's like you say for a year of your life, that's considered. So they count different diseases. So like cancer might disrupt your life, say for 2 years, but depression could disrupt your life for quite a number of years actually, for a lot of people, especially if it's what we call like a recurrent depression, episodically recurrent. It keeps coming back again and again, if that makes sense. Okay. So all that's pretty important to remember as you consider the differences or the impact of depression itself. For cancer patients, so another example as well for depressed individuals, why depression matters is when they, for example, when they go to nursing homes, if they come to the nursing home already depressed, it increases the likelihood of not surviving beyond their first year. So that's an example for how like depression plays a role in survival. For cancer patients, it also does the same. It impacts, number one, their quality of life. If you are depressed, already you have cancer, but you also have to deal with the symptoms of depression. At the same time, you have to contend with your own decision-making process. So remember I talked, one of the symptoms of depression was that cognitive slowing, so difficulty with concentrating, difficulty with making decisions. So that usually actually results in cancer patients delaying their treatments. They're indecisive about their treatments, they're slower about seeking out resources. So if you have to call insurances, you have to call different hospitals to compare prices, if you have to do those kinds of things, but you're already depressed, it makes it a lot harder to do. You don't even want to pick up the phone to do that. So depression does matter. It slows your treatment down, it slows your survival rates, is what we call it. So there are studies done for different kinds of cancers. Two big ones actually that were done. There was one that was done in Scotland, over 20,000 patients. So different kinds of cancers: breast cancer, colorectal, gynecological, and prostate cancers. And they compared all of them, patients with depression and patients without. And patients with depression were associated with worse survival. And another similar study, this was about over 13,000 patients with diffuse large B-cell lymphomas. And they were compared with patients with no mental health diagnosis versus patients with a major depressive disorder. Their 5-year survival rates were the worst for just major depression. Anxiety also is worse than people without any mental health diagnosis, but not as bad as depression. Depression was the worst. Interestingly, actually, people with depression and anxiety fared better than people with depression only in terms of survival rates. So my own personal hypothesis when I hear stuff like that is anxiety can be a good thing, because anxiety gets us motivated to do something. It gets us to prepare for things. So it pushes us to make decisions, it pushes us to do something. That's what a lot of anxiety does. So interestingly, people with depression and anxiety fare better in terms of survival than people with depression only for their cancer 5-year mortality rate.
How do we
Yes.
How do we give advice to the depressed to stop depression? Because as a member of the visitation team, we go out there to visit people who are ill.
All right.
Sometimes who are depressed, and we have difficulties to talk to them, to stop from having this depression. How to encourage them?
Okay, good. So the question I'll repeat for everyone is, how do we give advice to people whom the FBC care bears are visiting? Because it's really hard, because it's hard to stop that depression. And I want to say in response to that, someone came up to me right before we started today and asked me what's the difference between like a psychologist and other types of therapists. In clinical psychology, we train a lot of our students not to give advice. Our goal is not to tell people what to do, because if they could, it'd be just easy. We just need to, you got to do this. And so we are not trainers per se. We are educators sometimes, but a lot of times we are listeners and we are facilitators. And the goal is always to empower people. So that's why we don't give advice as much. That said, at the end of today's talk, I still have the pointers for the visitation teams, what you can do specifically. So I use the word encourage in those. It doesn't mean advice, but it's just encourage them in your own way. Not telling them what to do, but there is a way of telling them what to do. I'll cover that at the end of today. Okay, so just
As a depressed person, let's say I'm a depressed person, how do I stop my depression? It's very difficult, right? Even the mother goes to the daughter, let's say the daughter is having depression, the mother also has difficulty to stop that. So how that person who is depressed to stop that?
Okay, the question was, as a depressed person, how do you stop the depression? Okay.
That person who is suffering from depression.
Yes, for that person who is suffering from depression. I will say there are no easy answers per se, but a big part usually comes from them wanting to get better first. So I have two types of people that show up in my office: those who want to be there, and those whom someone else wanted them to be there. Right? And for those who someone else wanted to be there, the first part of the work is getting them to want to be better as well. Because it's when you're depressed, it is very easy to sometimes throw yourself a pity party. Like, woe is me, I'm suffering my lot in life, and maybe there's a lot of blame and a lot of, I don't want, I want this to go away, but I don't want to do anything different so that this goes away. So getting them to want to make the change is the first step, typically. But if they come in ready and they are motivated and they say like, I really don't like, I know I need to do something different, I just don't know what. Can you help me? Then that's where we work with them on different things lah. So depending again, so the different types of depression, right? So as I said at the start, three different big categories. But then even within the same category, like major depressive disorder, there are different types of depressive patients because different symptoms. So a lot of it is trying to help them with their specific symptom set, right? So if, say, for example, sleeping is one of their difficulties, then we look at sleep hygiene. Like how well are they, like what are the factors that's impacting their sleep? Are they practicing good habits? A lot of people before they sleep, they scroll on their phones, and sometimes a lot of them, which actually facilitates depression, they do this thing we call doom scrolling. Have you ever done that? Where you're on a video after video after video? That's called doom scrolling. You're just watching the next one that pops up. And social media is very good at, capturing our attention for that, right? So there's different things that we will do, and then so working with them on shaping some of the things that they can do differently, if that makes sense. There's a lot of other things as well, but it's very hard to compress a few years into a few minutes, but yeah. So basically I think the big part of understanding why depression is a big deal, because remember, one of the 9 symptoms of depression is suicide. And when you think about it, already cancer increases depression, which means cancer can also increase your suicide risk. In fact, it is also higher for patients with cancer to feel suicidal, also act on those suicidal thoughts. And I'll talk about why that happens as well, in particular. So, but not just cancer, remember, but a lot of medical conditions that people feel depressed and even actually end up taking their life, even though at the same time they're seeking treatment for their health condition. They will say like, no, they will eventually, in some ways, you can call it give up, and then try to take their life. That happens. Okay. All right, so we can go to the next slide. This is kind of an overview of understanding suicide. Jonathan? Maybe he's got his headphones. Next slide. Thank you. All right. So, just kind of big picture, according to the World Health Organization, about 700,000 people die by suicide each year. So it's one of the leading causes of death worldwide. And we actually call this like one of the leading causes, specifically like a preventable death, meaning suicide and a lot of what we call like behavioral health. It's not just mental health, but behavioral health, what we do about our lifestyles. About half of deaths are preventable, like if we just change what we do about them. So meaning we can say like, well, sometimes disease states are hereditary, or it's based on an environment that's affecting us. But a lot of what we can do about it also matters. About half of it, if we change what we do, you would see the death rate plunge. Okay. Just kind of really understanding, I mentioned this just now. In Malaysia, it was, maybe I did, sorry. In 2019, Malaysia recorded a rate of about 5.5 suicides for every 100,000 people. So that's the total estimated in 2019 is about 1,841. That's about 5 deaths a day, people who are committing suicide. So that's quite a bit. If you think about it, like 5 people dying every day from what we call a preventable death. And so I just want to make some distinctions at this point here. So if you're a marketing guy, you sometimes try to split your demographics, right, into looking at different segments, market segments, right, populations. Likewise, we do this also when we think about healthcare populations, specifically the population that's suicidal, all right? So I want to distinguish between 4 different types of suicidal people. One is the suicide ideators. These are the people who think about committing suicide. They think about it a lot. They think about it though, but they haven't attempted it. So that's that second category, the people who have tried to commit suicide, okay? Who have already thought about it, already tried it, but did not die. So those are the attempters. Then there's a third category we call the suicide completers. Those are the people who tried to commit suicide and died from committing suicide. Okay? And then there's a fourth category of people, what we call people who have what we call parasuicidal thoughts or actions. Parasuicidal is not quite exactly wanting to die. They don't really think about dying, but they do things to endanger themselves or harm themselves. So I'll give you some examples. So I don't know if you know, but some people cut, right? They'll cut their hands, they'll cut their thighs. Some people will drink a lot, and they will drink recklessly. Some people will drive recklessly, right? They are not quite, it wasn't like I drive real fast and crash into something, right? But I'm driving recklessly because I don't really care. Okay? So those are more parasuicidal. So some of the parasuicidal end up actually dying. Okay? But not the ideators and not the attempters. Okay? Some attempters eventually become completers. Okay, if that makes sense. So there's distinctions between each of these groups. All right? So a lot of people that you will meet in your home visitations as well, that I see in my office, are ideators or attempters, because they're still alive. I had this guy come in my hospital. He was what we call a lot of like medical providers and some of the interns who were before me kind of considered him like a revolving door. He had attempted suicide 4 times in his lifetime, and pretty intense ones as well. He once tried to hang himself, literally tied a rope, swung it over, pulled, but the rope broke. He was kind of a big guy, didn't die. Someone found him unconscious, took him to the hospital. Once he tried to jump down from a bridge, one of those overpasses, a highway overpass. And then he tried to time it such that when he jumps down, the car underneath would hit him at the same time. So he thought, confirm, can make it. So what happened instead though, he jumped, he fell, broke his hip, the car swerved and missed him, and then brought him to the hospital. Right? And then one more time he tried to shoot himself. As I said, he was a kind of a big guy, but the bullet got lodged in his rib and didn't penetrate any organs. So it was very fortunate. But a lot of his attempts basically were quite lethal. So we look at lethality is one of the things when we consider risk. I'll talk about risk factors later on when we assess them. But there are people who try different things. So I want to distinguish basically that there are different types of people with in that suicidal population, okay? So again, attempters and completers, for every completed suicide, there is an estimated 20 to 25 people who attempt. In Malaysia, I looked at the statistics for Malaysia, they estimated at least 15 attempts per completed suicide. And in Malaysia itself, the overall estimates for suicide and attempted suicide, a lot of experts actually think that it's kind of underreported. The actual number is probably higher than what it is. There's a stigma to being found out by police or coroner that, oh, you completed suicide. So for the sake of their family name, they don't say it's suicide, right? Police reports will maybe doctor it a bit or change it a little bit to shade some of that stuff. But the Ministry of Health in Malaysia actually thinks that maybe the number of people who are actually dying by suicide is much higher. Yeah. So as I said, they said it was maybe in 2019 it was 5.8, maybe 6 for every 100,000 people. But the Ministry of Health is estimating between 10 and 13, so almost basically double that. Yeah, a lot more people. But again, culture matters. That's part of why when you live in a culture that there's taboo, I guess, and shame to the family if you committed suicide. So just maybe some random, also quick comments. Among advanced nations, South Korea actually has the highest per capita per population for completed suicide. They have actually about 34.9 completed suicides for every 100,000 people. Lithuania, Eastern Europe has the second highest, like 33.1 cases of suicide per every 100,000. So some of these, I guess like in Korea, for example, advanced countries with good reporting mechanisms, like you can see also like a lot of suicides. At the same time, makes you wonder, there's a lot of different factors that drive into depression and specifically suicide from depression. Yeah. So, as I said earlier, suicide is considered preventable death, and studies show that having good mental health support, good crisis intervention, and community resources can reduce suicide rates. So, community resources can be anything from those NGOs to like hotlines. How many of you know how many hotlines, suicide hotlines, are available in Malaysia? I didn't know this until recently, because as I was preparing for this talk. Someone said 5? Okay, good guess, good guess. Others? 9? Very close. Very close. Yeah.
So many.
Well, yeah, I don't. So I think there are a lot of different organizations, and it depends on how well they publish themselves out there. But in a very quick Google search, I found 8. And the common one, I guess, a lot of people think of is like befrienders, right? A lot of people heard of befrienders. In the US, I think the idea of like having community resources is so big that not only, so you've heard of 911, right? When people say call 911, call emergency services, but there's 988 in the US, suicide hotline. So they made it such that it's easy for anyone can remember, just call 988. I used to, when I first started practicing, tell people, here is the National Suicide Hotline, which is a 1-800 number, which has like basically 10 digits they have to remember. But by the time I left the US, it's 9, shortly after I left the US actually, it became 988. Congress funded that initiative to make it easy for people to reach out for support right away. Stuff like that actually really matters, because in the moment of crisis, it's easy for people to remember, just call this. It's very easy for me also to help people call 988, and they will remember to call. I mean, it's easier to remember because it's almost like 911. So Malaysia's not there yet specifically, I think, but over time we'll get better with different things. But we do have 8, which I'm encouraged by, because I didn't know there were that many. Some of them I think are religious based, from the names at least. But certainly there's a lot more initiative and impetus. So when we talk about community resources, I see I spent almost 20 years of my life in the US, and after having come back, one of the biggest changes I've seen is that there's a lot more mental health awareness embedded into churches as well. There's a number of churches I don't really know out there outside of FBC as well that actually offer like a counseling support as in ministry. So some of them have like lay counselors, people from the church who are trained to provide counseling. Some of them have licensed or intern counselors or pastoral counseling who are trained specifically in counseling. And so there's that from a number of churches. So I mean, my understanding, some of the bigger churches essentially with more resources and bigger congregations can see that need, is also stepping up to fill that need. Okay. All right, so the final comment I want to say that, understanding suicide is that the impact of suicide is very large, typically. And I'll talk about that in the risk factors here shortly, but I just want you all to know that suicide impacts the community, impacts families right away, it impacts the friends of the person who committed suicide, and the community in the long run. And it can kind of have a domino effect if you think about it. So I'll talk about that specifically later on down the road when we talk about risk factors. So let's look at the next slide, which would be that of risk factors. Thanks. So there are a bunch of risk factors for suicide. People who attempt, who think about, or who actually completed suicide. One is what we call like comorbid health disorders. So it's not just depression, but you might have a few other mental health issues going on. I'm not sure if I put there as well, but yeah, so it's not just mental health. I want to say it's mental health and medical illnesses. So if you have mental health or medical illnesses, it increases your chances, because medical illnesses increases your chances for depression, which then increases your chances for suicide. Okay. Another one is substance abuse. People who use substances, and this is more common for, maybe a lot of people here are not so familiar with that, but if I work with populations of people who use substances a lot, they use drugs, they will shoot up drugs a lot, they will drink to the point of like it's terrible. Like they will have to start their morning with alcohol right away, and then all throughout the day they need some alcohol to sustain them. And so some level of substance abuse usually impairs your judgment and your thinking, which then makes you more likely to attempt at least suicide. That's actually related to one of them down there where I talked about impulsivity, right at the bottom, low attention control. So people who are more impulsive, sometimes you can say people with ADHD are more impulsive. People with ADHD have low attention control. It's hard to control their attention on things, so they are more likely to behave more impulsively. Same thing when substances enter our systems. It kind of makes us disinhibited. We care less about what's going to go on. We become more flippant. We become, uncaring, and then as a result, potentially attempt suicide. Sometimes some of that good news, FYI, is not a lot of people who are impulsive or use substances don't always complete suicide because they're not very skillful about it, meaning they didn't plan it very well and they just kind of started doing it without thinking too much about it, and then that results in them not actually finishing it. Okay, does that make sense? Yeah. So a few other things also. So I did talk about, so not just mental health, chronic illnesses, I mentioned that as well. Another one is a history of trauma or abuse. So this is for, especially in your developmental years, if you have that history, if someone has a history of being a traumatic history or being abused when they were younger, the way they perceive themselves, the way they perceive people, and the way they perceive the world is different, which makes them a bit more susceptible to depression, also suicide. Because their resources are less, the way it's kind of like it tints their lenses from an earlier age. It reduces their resiliency to deal with things from an earlier age. And so stuff like that will impact their ability to push aside those thoughts that come. Social isolation is a big one. So I know we talked about this in the past as well. For a cancer patient, sometimes, or just kind of anyone, when you have a medical condition, sometimes some of us are very private beings, right? I have parents who are lean on the paranoid side of private. They really don't want to share anything with people, sometimes even with me. So I can appreciate, I guess, the desire to want to keep things very private, but sometimes what happens is not just we keep it private, but we isolate ourselves from people. We take ourselves away from the very people who could help us journey through what we have and have that quality of life. And that also impacts both depression and suicidal ideation. Previous suicide attempts, considered one of the big predictors of future suicide attempts. So the dictum is past behavior predicts future behavior, and which is generally true. So which is why we pay close attention to those who have attempted suicide. So the guy I was talking about earlier who tried to kill himself 4 times, no one really wanted to provide service. Always in no one. Not a lot of medical providers or psychologists wanted to work with him because kind of a liability. When you consider it's like, I'm going to work with someone who's probably going to try and kill himself on my watch, right? So I don't really want that attached to my, my care. So I was a bit different, I guess, mostly because I wasn't licensed yet. I was practicing under someone else's license when this happened. So it's like, yeah, sure. If anything happens, it'll be that person's license. So I started seeing this guy, which actually really worked pretty well, because while I was seeing him, he was not. Because he came inpatient basis, and then he moved with me onto an outpatient basis, and which means I saw him regularly in the clinic, not in the hospital. Okay, and that actually prevented him or helped him not have to come into the hospital on an inpatient and stay overnight for a few weeks at a time. And just someone to journey with really matters as well. So another one that can predict, or at least a risk factor for suicide is the access. So you will sometimes hear, like if in the US in particular, they are very particular about asking about what kinds of access do you have? Do you have access to guns, knives, medications that you could overdose on? You know, and usually they tie that into the assessment of the plan. So they want to understand, what do you want to do? How do you plan to kill yourself? Having that open conversation. Okay. And then they try to basically talk with family members, include them in the support plan, the safety plan, to restrict access. So providers themselves, they might say, well, you think about killing yourself with this, then I don't really want to prescribe you this, like these drugs that you might take, that you might overdose. So they will select a different subset of drugs that that's very slow to the, I can't remember what's the word for it, but to the lethal dose essentially. You can take a lot of it and still not die. Then family history also matters. This is part of the domino effect I was talking about earlier. So one of the things that we know that affects people in terms of whether they also think about suicide is having a close loved one. So either a family member or a friend who's close to them who has passed from suicide specifically. So a lot of the times when I have talks with patients about their thoughts about suicide, I talk about this, suicide being a domino effect itself, which kind of opens the eyes for some people, because when they think about it, they say, for example, I talk about this later on also, like say for example, I don't want to be a burden to my family, so I'll offload myself, right? So if I offload myself, but then if you offload yourself rationally, you increase the chances for them as well to think about that, especially the people who love you, because when they love you, they have that tie with you, and you took that away from them. It makes them consider it more strongly. Your actions make them consider that, if that makes sense. So that itself becomes something of a risk factor. So I usually tell them, so be that domino that doesn't fall, so that other dominoes don't fall, if that makes sense. So you can prevent that ripple effect, so to speak. A few other things as well, life stressors, crisis moments, so situations such as financial difficulties, relationship breakdowns, significant life challenges, maybe job losses, anything that can be big, okay, can kind of really impact your decision to make maybe an impulsive, because the life stressor, the problem seems so big, I can't see a way around it, I'll end my life. So those are the thoughts that come in as a result of life stressors. Okay, gender differences. Just like depression, women are at higher risk for attempting typically, but men are at higher risk for completing. So that's usually typically the result of men being much more lethal in their approach. So women tend to go for the softer means, the painless ones they call it, whereas the men tend to do things that like they're not going to make it out of it typically, if that makes sense. All right, and I talked about impulsivity earlier on as well. Okay. All right, next slide. So just a few more slides. So the talk of today, the first two words, confronting despair. So I want to make sure that we understand what the role of despair is in depression and in suicide. All right. So despair and hopelessness are significant contributors to depression and then suicidal ideation. So typically, when we think about this word despair, we're thinking about two kind of things: helplessness, hopelessness, especially hopelessness. So hopelessness, when we can't see very much into the future, our vision of the future becomes very narrow. It kind of comes into a pinprick of a tunnel vision. And all we're seeing at the end of the tunnel is our pain in that moment. If you've ever had to talk to someone about when they're contemplating suicide, they are not thinking about other things because they're thinking about the pain of the moment, the suffering that they are in. So that suffering makes them unable to see alternatives, to see other options beyond the moment. And they can't see their way out of it. Okay. So I have up there in that slide two different questions that is measured on the BDI, the Beck Depression Inventory tool, which basically tells us that hopelessness has a very significant positive correlation with suicidal ideation. So people who rank themselves, like say on a scale of 0 to 4, right, on the it's called pessimism here, right, on the question number 2. So the question is, it basically asks people to rate themselves on a scale of 0 to 3 there. 0 is I'm not discouraged about my future. 1 is I feel more discouraged about my future than I used to. Number 2 is I do not expect things to work out for me. Number 3 is I feel my future is hopeless and will only get worse. So you can see an increasing grade of severity from 0 to 3. And suicidal thoughts or wishes, again 0 to 3. 0 is I don't have any thoughts of killing myself. Number 1 is I have thoughts of killing myself, but I would not carry them out. Number 2 is I would like to kill myself. Number 3 is I would kill myself if I had the chance. So stronger and stronger statements again, right? And you will see for people who rate them, so these two items are very strongly correlated, meaning if you are 0, you're likely to hit score 0 or 1, you're likely to score 0 the other. And then it goes up. So if you're likely to score 2 and 1, 1, 2, 2, 3, 3. It's almost like it's almost a perfect correlation, not quite, but it's a very strong correlation between the two. Which tells you that hopelessness, despair, is linked very much to suicidal thoughts. Okay. So, big picture, I think suicidal ideation can lead to a lot of different things, but cognitive distortions is one of them. It changes how you see things. We call that your lens gets colored. So when depression sets in, we tell people sometimes it's like wearing a yellow colored sunglass. If you wore that all the time, the world will just look yellow to you. And so when you're depressed, also same thing. If you're depressed, you might see things, you might filter things through that depressed mindset. And then you might lose motivation, which is that withdrawal from people, activities, that loss of energy, and like I don't really want to do stuff anymore. You might feel increased emotional pain, which is that intense suffering. So in some ways, despair actually amplifies your pain. It actually makes the pain worse on the emotional side. So I work with pain patients also. I forgot to mention that in medical settings. So these are people with medical conditions that have the pain level is very high that they have to deal with. But a lot of times, if they have also like depression, it makes it even more painful, and sometimes really bad. They're screaming for their doctors in the wards, like literally screaming for the doctors because the pain for them is intolerable, like unimaginable. And it's always a 10. When you ask them to rate from 1 to 10, the pain is always 10, the worst they've ever experienced. And then also, it impairs your decision making. So just like depression, it impairs it. And so meaning hopelessness impairs decision making. And the last one, actually, that sense of burden. I'm going to spend some time talking about that really quickly, because there are a lot of people with cancer who specifically feel like they might be a burden to other people. And oh man, I think so. There are some studies that basically link what the sense of burden is when people are depressed, when they are hopeless. And what is really interesting about that study that particularly talk about when people feel a sense of burden to others is that subjectively they feel it even though other people do not see them as a burden. So when you ask them to rate themselves, they call themselves a burden, but no one else around them calls them a burden. So this is their own perception of themselves. So again, when you are hopeless, you might see yourself that way, which might then make you think about suicide, even though no one wants you to go. If that makes sense. So that reinforces their desire to end their life instead. Okay, so we can go to the next slide. I have just a few more slides here, so bear with me. I will try and end in about maximum 10 minutes, and then Q&A for the rest of it. All right. So protective factors, just kind of really quickly, a lot of the protective factors are the opposite of the risk factors. So when you think about it, if you have good social support, right? If you have positive, meaningful, warm relationships that support you, you are much more likely to weather any medical condition, not likely to be as susceptible to depression per se. If you have good coping skills, so we talk about different ways of coping. Actually, one of the not good ways of coping is what we call avoidance-focused coping. We sometimes avoid things. So for example, if our boss gave us something to do, we didn't complete it. We did not complete the thing that we had to do, and then they asked us again, where is the thing? We avoid answering the email. We avoid walking by the boss's door because I don't want to be asked, right? That's an example of avoiding. But a lot of avoiding also happens, focused coping also happens, which then presents as kind of not a very good coping strategy. Sometimes it's okay to put things off. It's procrastinating, right? Okay to procrastinate, but then come back to it again when needed, especially making yourself do it, the thing that is hard. So, a few other things, just kind of protective factors, basically overall having hope and purpose. And in there, I just want to say the big thing that a lot of times we assess a protective factor is how much are they thinking about the future. So for example, they're thinking a lot about killing themselves, thinking a lot about it. Like we are talking about on a weekly basis, sometimes daily basis. But they're also thinking about the trip that they have planned. They have that event, an outing that they have. So meaning they're going to go and travel out of the country with some friends here. Okay, so they're talking about that. Then they're also talking about, say, an outing they're going to have with their children or their parents, or their friends. So what we call that future-oriented thinking, some plans for the future. When you have some plans for the future, it inhibits it. You're not as tunnel-focused necessarily, which then helps you expand that view. So we do all we can to really expand that view. So sometimes I really flesh it out, even though it sounds like it's part of therapy, even though it doesn't sound like it. So someone says they want to go to school. Okay, tell me more about going. So meaning they finished high school, but they never went on to college. So okay, tell me more about your college plans. Like, what do you want to actually do? You know, what's your interest? You know, what is your, you know? So it gives them a flesh. They start to flesh out their dreams a little bit more, which then gives them some sense of hope that, well, not everything is entirely hopeless, right? Okay, so for the sake of time, I'm going to move on to so just maybe last comment, like being employed, being financially stable, those are things that kind of help insulate as well. against suicide. I'll move on to the next slide and maybe come actually to the origins of today's talk. I think the last time we had this, that I was talking to FBC Care Bears, it wasn't called Care Bears yet then. I talked about this idea of iatrogenic. I don't know how many of you remember, but the term iatrogenic really means that as a result of it's being induced by the person. So I want to emphasize here that talking about suicide is not iatrogenic, which means talking about suicide with the people who are thinking about suicide doesn't make them suicidal. Okay? Because sometimes there is a stigma from people. It's like, I don't want to talk about it because I'm going to embarrass them or I'm going to make them think about it. Because if I ask them, they're going to think about it. Right? And that's not true. In fact, the inverse is actually true. Talking to them about it, especially if they're already thinking about it, really helps them not think about it. It helps them. So there's like good ways of assessing and intervening in that and tracking their suicidal thoughts that a lot of people in the process, they say, I felt really hurt when you are asking all these questions. It helps me feel that someone cares, which then also gives them a better sense. It's almost like tracking your weight if you want to lose weight. So you start tracking your thoughts, which then when they're tracking their thoughts, they figure out ways to deal with it more proactively. Okay? So talking about suicide is not a bad thing. Okay? That said, I want to say that I don't expect all of y'all to become good at talking with people because it can be very uncomfortable. But if you hear someone express certain kinds of thoughts that relate to like they're thinking about ending their own life. They're not thinking about the end of their life, but they're thinking about taking their own life. So sometimes there's like soft things that we look at also. Oh, are they starting to give their things away? Are they starting to say their goodbyes to people? Those are like soft signs that they are starting to get ready to do something pretty drastic. Okay. So, but that said, in the clinical setting, typically in a medical setting, I just want to say the assessment of depression, sometimes some of you might have gone to clinics and done like surveys at the start. So PHQ-9 is very common. Yes. Few more minutes, 2 more minutes. Maybe more. But when you enter the clinic, they give you a survey so that they can actually assess your depression. Nowadays, a lot of GPs also, I just recently did the health check. They include that in the screener. They check your depression, anxiety. So PHQ-9 is one of them. On the next slide, just real quick. So the PHQ-9, if you just look that up, that's a physical health questionnaire. And they ask you a whole bunch of questions that basically, there's 9 questions there. And the 9 questions relate to the 9 symptoms, right? So it gives them a sense, okay, which ones you might have, okay? I was talking with that doctor, she said, a lot of people don't understand, because the question asked, in the last 2 weeks, have you had any of these 9 things? So specifically just looking at right now, are you having any current depressive symptoms? But sometimes people don't understand, so they're like, I've had this before, I've had this before. But then in reality, right now, they don't have all of these symptoms. So reading the t-shirt, I remember the doctor telling me, just Malaysians don't read instructions on. And I had to laugh. Because she said, good thing you read, she was telling me. So, all right. And then I just want to say real quick, assessment and management of suicidal risk. The next 2 slides actually pertain to how it's done in the clinic by medical professionals typically. So they will ask a series of questions that probably, it's the next slide. Is it too small to read? If it is, I'll just skip it also. It's too small, I apologize. But I'll just kind of read that real quick. They'll start with the question like, most people with cancer have passing thoughts about suicide, such as, I might do something if it gets bad enough. And then you ask that. So you start by acknowledging that this is kind of normal for a lot of people. And then you ask, have you had thoughts like that? They might do. So this is what it looks like in a clinic setting, right? And then And then they might ask even more specific, have you had thoughts of suicide? Have you thought about how you would do it? So ask about the plan, and then ask, have you ever tried suicide? Remember, again, that's one of the risk factors, right? And then they'll ask, have you ever been diagnosed with mental health conditions, been treated for a psychiatric issue? Again, one of the risk factors. So they ask you all these questions related to risk factors, and then kind of formulate a risk profile for you, essentially. So it goes on all the way to that question, have you lost anyone close to you in your family? So, and then and then that person died by suicide as well. So, next slide, please. Second last slide here. For the management of suicidal risk, in practice, the big goal a lot of times for cancer physicians is to attempt to prevent suicide driven by desperation due to the poorly controlled symptoms of cancer. So they usually try to, obviously tackle the disease, but they also track a lot of other things as well. So what they might do is if they start to detect mental health symptoms, they refer quite quickly. So in the US at least, I got referrals very quickly from cancer docs. Sometimes they'll call me directly into the office as the patient is there. They'll page me, I'll come over. And that happens. So they pay a lot of attention to the symptom management of things, and then they limit access to medications where it may be lethal to overdose on very few medications, very little amounts. And then they call the patients in more quickly. So if you've ever gone for any kind of chronic issue, the doctor will tell you, come back in 2 weeks, maybe, or versus 3 months. But if they're not confident, they might tell you 2 weeks or a month, right? They keep more frequent contact with you, right? Again, it's not so they can make more money, it's so that they can do their due diligence in checking up with you on what kind of care you need. And then a big part of it, sometimes they mobilize support for the patient. So in the US, I don't know about Malaysia. I'm not very familiar with the cancer setting here in Malaysia, but in the US, we work in teams. So as part of the cancer docs team, they also have social workers, they are psychologists, but social workers help with a lot of other factors, including, like, say, for example, housing. If you need to get cancer treatment and you need to be closer to a treatment center, you live 2 hours away, we'll help you figure out housing. It helps figure out all sorts of things, like even so you can't afford cancer treatment, okay, I can walk you through the process, navigate the healthcare landscape so that you can still get resources to treat your disease. So it doesn't leave them entirely hopeless. So they mobilize the system, and then they refer them to lots of support groups. The last slide, if we go to the very last slide, so 2 slides from here, the next one, yeah. So I'll give you an example. So there's National Cancer Society of Malaysia, and they run a bunch of support groups, actually. So you can think of support groups as a little bit like life groups. It's like journeying with people in the same stage of life with you typically. So most life groups are built around like people who are fairly similar demographically. So like I'm in one where, because I have 3 like kids, youngish, so between 5 and 13. I am in a life group where there are parents with younger kids, not in the teenage age range, most of them, but mostly in the younger range. So it helps when you're journeying with people in life. And that's true also for support groups like this. So Cancer Society of Malaysia runs a few different ones, right? You can see up there like a women cancer support group, a young cancer survivors group, a prostate male support group, and then there's a lung cancer support group, and then there's a caregiver support group. So there are all sorts of resources out there like that. And I have one last slide, but I want to actually make time for questions. But in my last slide is actually the application portion of how does all of this apply to you, right? So Jonathan, if you go back to the slide right before this, it's talking about application of skills and abilities that you need to have as you are working with people with cancer who may be depressed and may be suicidal. So the first skill is really a very important foundational skill. And I spent the last talk talking about this: active listening, validation, being present in the moment with that person. So when you go and visit with them, put away distractions, talking with them is not going to be like, it's Dr. Peter here? Oh, good, good. He's left? No, that's okay, that's okay. I just didn't want to offend him. It's not like listening to a sermon sometimes, where we can kind of like nod off, or we can like check our phones, because it's usually in a small group setting. So we start to do this, say even at a dinner table, right, among family, like my kids don't have devices, but I also am mindful about putting away my device when my kids are at the table. And the idea is to say that I'm here with you right now, right? And so being very mindful and being very active, being present is very important. And being able to validate people, so sometimes the knee-jerk reaction, right, if someone tells you they are suicidal, right, is to try to solve that or to take that away, right, to advise that away, right, because we don't want to hear that so much, or we're not comfortable with that. So, but validation is being able to say, like, I really get where you're coming from. So yesterday I was in a session with a family, it was a grief counseling session where they had lost their dad. And then the daughter was describing her feelings about how she's not, basically my family is no longer complete, right? And it was a very emotional moment as well. And then mom chimed in, and instead of pushing her down and say that, mom also acknowledged that I also feel my family is not complete. We are missing him, we've been missing him. Right? So my family is not complete. At the same time, I'm also doing these things because I'm asking them to actually give feedback to each other, to help each other on what they're struggling with. So get them practicing how to do that. So mom said that, so I thought that was very powerful when she said, I also, so you're validating this, right? That this sentiment that you have, I also see it the same way, that I don't feel it's complete. It just feels like something is missing. Right, so that someone is missing, this family is not complete. And then she proceeded to provide some suggestions that were really, I thought, meaningful, for the daughter to also try, So on my side, what I'm trying to do is this A, B, and C that can kind of help with this situation. So, same way, right, which is why I say, one of the abilities you need to have is to be able to empathize with them, right? To sit with their suffering and not have that I want to fix it mindset. What you're trying to do is to actually empower them, which means you believe they have the right to make choices. And if they have that right to make choices, your big goal really is to just be there with them and sit through that suffering, and then gently, I want to say that this, being there and being able to sit through with them provides a container for all their emotions. So right now, when they're going through a lot of emotions, especially hopelessness, a lot of those emotions are just spilling out, and it's got nowhere to go. And you being there, doing that for them, provides a way for them to feel like I'm heard, I matter, and I'm important. And that stuff is much more powerful than you can think it to be. So that's why I said earlier with the advice, we don't start with the advice, we start with the listening. And then we move on to creating that safe space where they don't feel like they're going to be judged. Right? Already there's a stigma with suicide, but then if I have to tell, so sometimes, like parents, I get messages from parents like, oh, I found razor blades by my kids' table, the bedside table. They're thinking about, they're cutting, or they're thinking about cutting themselves. What do I do, right? I say, have a conversation, but don't, make sure it's a safe space, that they don't feel like you're there to attack them and like judge them, like why are you doing, it doesn't have that judgmental vibe to it, basically. Stay away from that. So, and then the next three things are what you can actually do. What do you encourage? I don't say advise, I say encourage. So if you hear that they are isolating themselves, if you hear that they are dealing with it alone, something you can tell them is like, actually there is pretty good help out there for this, I mean, the reason why we say there is because the data says that 2 out of 3 people who seek help for depression will improve from seeking help for depression, whether it be with medications or with therapy. It gets to be 3 out of people, so it increases from the mid-60s to the mid-70s if you do both medication and therapy. So your odds of recovering faster is better. Sometimes they don't want to because they're like, I'll snap out of it eventually. But the recovery rate for a lot of people is anywhere from 3 months to over a year. And sometimes that over a year of, remember I talked about the burden of disease, it just lasts a long time. Imagine it's 1 year this time. The next time is another year before it rights itself. And then the longer you take to address it, sometimes it just recurs back again faster. So there is some danger in that, which is why interventions are important, useful, especially if people are isolated. So encouraging them to seek professional help, whether it's from medical professionals, mental health professionals, support groups like Cancer Society, and then community resources, those helplines that we talked about earlier. Encourage physical activity. Surprisingly enough, exercising improves depression. It helps with a lot of things actually. The biggest predictor for like taking away dementia right now, or preventing dementia, or like being more healthy and not having dementia, is actually exercise, more than anything else. So active body, active brain, kind of remember that. So because exercising gives your body that natural brain chemicals to also right itself. So if you see that they're isolating themselves, ask them to get out. If it's hard for them to get out, say, hey, let's go together. Let's go for a walk around. There's a lake right by SS12, right by the park. There's Subang Ria area. Yes, correct. Yes, and so there's a few lakes. You can walk around that area. It's kind of a nice. The smaller one. There's a bigger one. If like more like scenic walk and not too, but if you like maybe a more bigger challenge, you can go for a hike, Bukit Gasing, whatever it might be, right? But just get out there, spend some time together, which is the next part. So encourage connections, right? Encourage them to come. So it could be as simple as like, hey, you want to come for that thing tonight? You want to come for that? Is it tonight actually? Yeah. It's tonight. Yeah. Okay. Yeah. So for example, right? You could sponsor them a ticket, whatever it might be, things that can help. And the last one is really just educate yourself. The skill sets you need to have, really just spend some time learning. So like today, I tried to give a very compressed, and I apologize if some of it is maybe a bit too technical or too factual, too much like facts. I just try to weave in there, but I hope that's helpful to your comprehension of what is this disease state and why it matters and how it impacts cancer patients and how it impacts what you do and why you want to sit with people. So, with that said, I have come to the end of the talk, and I would like to invite questions from the audience. I apologize for going a bit over time, but we still have 15 minutes yet.
Any questions? Any questions for Dr. Daniel?
Yes.
Yeah, Doctor, I think what you discussed today is very enlightening.
Mm-hmm.
And what would you do if somebody asks you a question, why me?
Right, so those are like existential type questions, we call that, right? So it's and sometimes they have like ideas related to God as well, So I just want to say that it's a process. When people go through that, there are stages to kind of understand with that. But if people ask, so the very short question to why you, I don't say this right away, and sometimes it might be invalidating, and sometimes I'll just say, yeah, I will acknowledge, I'll validate. It feels like it's very personal, that you've been picked on, or you've been judged by God, or you've been punished, maybe even, right? So that's the validation piece, right? I'll acknowledge it. At the same time, I will also eventually, if I have a good bond with them, a strong rapport, I might chuckle a little bit at that. And might even say like, maybe it's not you, right? Maybe it's not the way you had perceived this to be. Like these are life processes. So for example, the family I talked about yesterday. The daughter is talking about hating God, for example, existential again. Like why did God allow this to happen to us? My emotions are breaking because of that. And I'm okay accepting that because that's part of that process. And then knowing that eventually they see that this is maybe not them specifically. Eventually you come out and see that this happens to a lot of people. So God never promised that it would not happen to you specifically, if that makes sense. But in that moment, I can see why people would want to personalize it. So we call that like personalization, one of the cognitive distortions. They think it's just them, if that makes sense.
Yeah, my experience is with a kidney patient.
Mm.
And she asked the question, you're not well, why me?
Mm.
But you look at her, she's grossly overweight.
Mm.
So what would be your recommendation in this case?
I wouldn't, even if there were like factors and things that she was doing, I wouldn't point that out specifically yet. I will point out what she can do to improve, but not so much focus on why this has happened. I let that actually be the medical doctor's job. So sometimes I might say, oh, what did the doctor say? Like, why did this happen? So the doctor will be, it's really the medical doctor's job to be very cutting, and because they will see you for only 10, 15 minutes, but they will tell you, you did this, you did this, you did this, that's why this is like that now, right? So again, the preventable, that stuff, they will tell you, but it's their job to give you the news in a chop, factual manner, right? But when we are doing like sitting with people, if we do it, it might sound like we are not validating or we are blaming them. So they're still going through a process. They may know it factually, that there were factors that contributed to it, but they're not accepting yet that responsibility. And that is also a process, very slow process.
Actually relates to what you mentioned on the board. That's very useful. For instance, encourage help seeking from medical, and then support groups, encourage physical activity. So if you have a sickness and you doesn't move, really your weight will increase, right?
Absolutely, yeah. Yeah, absolutely.
I think much like you say, right?
Yeah, correct. And when we encourage, we do it in very soft ways. We don't say, sometimes you need to push it harder. Like say, I would say if it's husband and wife, yes, the wife can tell the husband, you need to, do this, right? Or vice versa. But if it's, like say, between friends, you can say that, well, you could try this, like this might help. I heard it's help, it's the encouragement that the way you plant it also matters in some ways, so that it's not so like judgy to the person who's receiving it. Yeah. Hope that answers your question.
If it is an emptiness situation, you mentioned depression, right? I think that a lot of depression happens when it's emptiness.
Yes.
Particularly when there are nobody to take care of them,
Yes.
and they are sent to the home.
Yes.
And most of them, they are sent to the home, but don't last more than a year. I want to know why.
So that has a few things to it, but I think a big one is the loss of social support part. When we talked about that, the risk factor, right? When you lose that support, we take for granted these connections that make life worth living. But when they go, then we realize how much they actually mean to us. And then part of it is also our perceptions on things. So, for example, I know this dad and son. So this son has had bedwetting issues, and then until quite an advanced age. And the dad used to be really grumpy about it, like frustrated, like, why is this happening? Why do I have to clean the sheets all the time, right? But then when he changed the way he thought about it, for example, so the framing matters, how you think about things matter. When he thought about it, he's like, there will be men who would wish to be able to do this. It can't be fathers who are not fathers, who would wish to have the chance, or who have an empty nest. I only get so many years with my son. So when he thought about it that way, it made it a lot easier to do. That nighttime changing. Because if you've ever had to change bed sheets at night, you know it's a tiresome chore. And if you have to do it regularly because your son is bedwetting regularly, then it's an even more frustrating chore. But how you think about it matters. So when you have the change of mindset, the change of that really frames things.
At the home, when you see them,
Hmm.
they don't talk very much. What is the reason?
You mean people that you visit or?
Yeah. I mean the home is
In the homes.
nursing home. Nursing home.
I think it depends. I think depending, because a lot of times people are, and I say I don't think just welfare homes. I think like they're leery a little bit of the people who provide welfare for a show once a year, twice a year. It's hard to build a connection. So unless you are intentional about seeing them, so I get that privilege because I'm a therapist. They come into my office on a weekly basis or bi-weekly, and then we can build that connection. But without that real connection with them, it's like you're a flyby. They're gonna, another guy come to, I tell my same story, but it's after this, they won't remember me after this weekend. So it really depends. If you have the time and the wherewithal to really engage with people and select, that's a rule of thumb. You cannot spread yourselves too thin. You got to pick people who you're intentional about to practice that active listening. So lots of good questions. I want to open the floor for a couple of people, but I saw Eve, you had your hand just now. Is it?
How can we provide support to those who are depressed, knowing that as a visitation team, we cannot visit them every day?
I think it's good to not visit them every day. So the question was, sorry, actually I repeated all the questions because it's being recorded. So, but the question was like, how do we provide support to those with depression when the care team, support team cannot visit them every day? Right? Of course, it's not feasible to. I also don't see patients daily. It is only if they are like in huge crises that I might see them more than once a week, and sometimes be available on my phone support. But otherwise, I don't typically see them more than once a week because the idea is that we want to space some of that out. The discussions that we have Sometimes have you had people just visit you and after they go, it's like, oh, that was good, but it was tiring, right? You can't do that every day, neither the recipient nor the giver. So it's okay to allow yourselves to not be forced to give all the time, but to make sure to schedule a follow-up. And I think sometimes in your session, the times that you meet with them, you can give a general sense of expectation, get a sense from them how often they might like, but also know yourselves, how often this team might like to visit with this people, this person. Okay. I saw a few other hands as well. Okay, yes?
You suggest that the team after the visitation they do debriefing.
Do I suggest a team after the visitation do a debriefing? I think that's fantastic if you guys can do that. Yeah, I think that would be great because it helps you all process. I think there should be a good debrief style also, but it's like what went right, what was good, what we all noticed, what things, the areas we could help in, or it helped provide. But again, help provide support. But again, remember when you're providing support, you don't do everything for them. Meaning, a big part is to empower them, to give them the tools to also do it. I'll give some examples. Sometimes I know there is a push or pull maybe to help people, to help fix the problem. Say, for example, if people need food support, because of the recent treatment they have upcoming, you can support them for a week, 2 weeks, a month maybe, depending on the type of treatment. But the reality is you don't want to do that for a year, right? Because that's disempowering. They will stop cooking, they will just not have to order any food, they just wait for you to deliver the food, right? So that's what I mean by empowering. Enough to support, but still then let them also be able to have that sense of, because it's good for us to do our own things. Good for me to do my own laundry, good for me to, I'm trying to say, fill in the blank, because it's my own sense of independence and I can do it. Okay. Other questions still? Yes.
Not really, but I just thought that you started with the 3 shades of depression. I think more likely in the general population and maybe even in your practice is that there's a question of anxiety, right? are you going to do a session on anxiety?
I haven't been asked yet, but yeah. So we will. That's feedback to the to the team, the leadership team for the campers. Yeah, you're right that it does affect. So the question was, we talked about depression today, but anxiety is also a very prevalent thing, and that's true. They both actually have very similar prevalence rates. Anxieties, there's actually more types of anxieties than depressions actually, because anxieties take different forms as well, and those get a bit more complicated. So yes, maybe one day if I get invited back. Other questions too? Yes.
Also pertaining to Owa's question, anxiety. So how does social anxiety develop in a young adult? And of course, to recognize it, they will be on their own, locked away from other people and all that. But in the first place, how does it develop? How does it become? Or how does a young adult suffer from social anxiety in this kind of world,
So the question is, how do people, or especially particularly young adults, suffer from social anxiety, right? How does that develop, right? So social anxiety is a type of anxiety, and the essence of social anxiety is a fear of evaluations from others. So you are concerned about how other people see you, judge you. So which is why it's like, say for example, people with social anxiety there's different facets of it, but different way it comes up. But one of them, for example, is public speaking. They don't dare to stand in front of people. It comes up because that fear of how people are seeing them affects how they perform. That is an evaluative aspect. Some people don't want to eat in front of other people. I work with clients who would buy food from a restaurant and go to their car and eat by themselves, right? Because they're afraid people would judge them as they are eating in public. Again, it's the fear of how other people would see you or talk about you or think about you. And that's why it's called social anxiety. Okay, so how it develops? It develops through like probably a combination of actual experiences where, say for example, people laughed at you. So the eating one, people laughed at you for being overweight. So it's like, oh, okay, so I can't eat in peace. So it happens a lot in American high schools. That's why you see all those movies where they pick on kids in cafeterias, with the bullying crowd and all that. But that's happened, it really does, where they get picked on, And so to avoid that social evaluation, they abscond somewhere else. Bullying and abuse. Okay, so the question is, does bullying come under abuse? Largely, I would say the answer is no. Abuse has 4 types, or we think about as 4 types. There's physical abuse and sexual abuse are the 2 most overt ones. So abuse means like it is a person who is disadvantaged or maybe a protected class is what we call them, has been taken advantage of by someone who knows better. So for example, minors is one, disabled adults is another, and elderly, so over 65 in the US. These are 3 protected classes. So usually with minors, they get taken advantage of sexually and physically abused sometimes. With elders and disabled adults, it's other stuff. It's either neglect, so that's a form of abuse where you don't care about them at all. You just leave them to fend for themselves. Sometimes it happens with kids also. But you leave them to fend for themselves, or it is the financial, so like emotional abuse, financial emotional abuse. So I twist them for my own financial gain. It happens to a lot of seniors actually, and disabled people, because disabled people sometimes don't know how to manage their finances, so they have a payee, and payees take advantage. There's a movie on Netflix about this stuff. Can't remember. There's this lady. Gosh, I'm blanking on her name. But anyway, who basically takes advantage of people in real life. for their own gain. So that's considered abuse. Bullying is a little bit different from abuse because those are the 4 classes of abuse. Bullying usually happens on a peer-to-peer basis. It's not like from a person of power to a person of non-power. But even then, with peer-to-peer, there could be differential powers lah. Some people are stronger, some people are better looking, some people are richer, have more social connections, and they harass other people. So I would differentiate bullying from joshing around. Joshing around is kind of, friends sometimes they poke at each other, they say stuff at each other back and forth in good humor. But there are sometimes it does go overboard, and it really is degrading to the point that it's degrading the other person. So bullying does have that physical component, does have that verbal component, the emotional component as well. But it is usually not from like a top to a lower, if that makes sense. Oh, sorry, it's not from someone who's in authority. So I remember I talked about protected classes for abuse, so children and adolescents, so up to 18. So if you're 17 and below, adults shouldn't be. That's why in law in US, the culture is that when you're 18, parents don't have to take care of you already, or you can leave the home already because you are an adult. By law, I don't have to take care of you anymore. So, which means I can leave you to fend for yourself because you are a grown up by 18. If that makes sense. So, but before 18, I have to take care of you. I have to meet your physical needs, your financial needs, whatever it might be. I have to not sexually abuse you, those kinds of things. But the parent has to do that for the child. But if they don't do that, if they take advantage of the child or an elderly, so over 65, or a disabled adult, that's considered abuse.
Okay, it's 4:30. We thank you so much, Dr. Daniel.
Thank you everyone for your attention and time.
And we hope that this session actually can give you the very helpful insight and knowledge of this depression. And we hope we can work together to serve our brothers and sisters out there who are suffering from depression or ill, who are ill. Okay, thank you so much. Yeah. Thank you.
Thank you guys. Yeah.
Next time. If you have any questions for Dr. Daniel, you